Hi, everybody, and welcome to Memory Matters.
A show that explores the science behind memory care.
I'm Sarah.
And I'm Ollie.
And this podcast is brought to you by Lizzy Care,
which is a solution that's designed to support and enable families and their loved ones who are going through the journey of dementia.
And despite our funny accents, Lizzy Care is based in the US.
We're memory care that's crafted by science and delivered with love. Who are we speaking to today, Sarah?
Well, Ollie, today we're going to be speaking with Dr. Sam Gandy, and he is a professor of Alzheimer's disease research at Mount Sinai, and he's the associate director of the Mount Sinai Alzheimer's Disease Research Center here in New York City. And in case you need any other confirmation of his all-star status as an Alzheimer's researcher, he also happens to be the chairman emeritus of the National Medical and Scientific Advisory Council of the Alzheimer's Association.
That is a lot. What is his research in?
Well, Dr. Gandy is actually an international expert in the metabolism of amyloid, and amyloid is the protein that clogs the brain in patients with Alzheimer's. In fact, Dr. Gandy was involved in the discovery of some of the first medications that could slow the formation of amyloid. So we had Dr. Gandy on the show to talk to him about medications available for patients with dementia. And I think the most important thing to remind our listeners is right now there is no cure for Alzheimer's, but there are medications that are used today, and these fall into two main categories. There are medications that can help mitigate some of the symptoms of Alzheimer's, and then there's this pretty new category of medications, and they're the ones that are attempting to slow the progress of Alzheimer's by targeting what underlies that disease process.
Can you say a bit more about the symptoms?
Well, as Alzheimer's progresses, the brain cells die and the connections in the brain are lost. And this is what causes the cognitive symptoms. So some of the medications like cholinesterase inhibitors and glutamate regulators, they help support the chemical messengers of the brain to try and stabilize memory, attention, language, and things like that.
Yeah, and there's been a lot of excitement about these new medications that might help reduce the progression of the disease.
Yeah, there really has. And Dr. Gandy certainly knows a lot more than I do. And we're going to hear from him in a minute. But speaking from a US perspective, the FDA has now actually approved two different drugs that have been shown to have some ability to reduce cognitive decline in patients with dementia. There's aducanumab, which goes by the name Aduhelm, and lecanemab, and that's sold under the label Leqembi.
Great. Well, let's hear from Dr. Gandy himself. Hi, Dr. Gandy. Welcome to Memory Matters. How are you doing today?
Very well, thanks.
Can you tell us a little bit about yourself and what you do?
Sure. I'm a neurologist and cell biologist at Mount Sinai, and I work on both basic research in models of Alzheimer's and in clinical trials and care for patients with Alzheimer's.
And do you work specifically with Alzheimer's patients or with dementia patients? Because what we've found out in the real world is that a lot of people use these terms interchangeably.
We see all forms of dementia, but obviously the most common form that we see is Alzheimer's. I think it's not so unusual that people use them interchangeably, but Alzheimer's is a specific cause of dementia, whereas dementia is just a general term for loss of the ability to think.
Dr. Gandy, you were involved in the discovery of some of the first drugs that lowered the formation of amyloid. Could you tell us what amyloid is and how it relates to Alzheimer's?
So amyloid is a normal protein that's in every cell of the body. And in Alzheimer's disease, the amyloid protein changes its shape, becomes sticky, turns into clumps, sometimes into fibers and plaques. And these are all deposits that can either poison nerve cells or activate inflammation.
Yeah, so it's the buildup of the amyloid plaques in the brain that really causes Alzheimer's. Is that right?
I don't think it's as simple as that, but that certainly can be an important trigger.
I wonder if we can talk to you about some of your own research. What are some of the most exciting things you've worked on?
There are a couple of things that we're working on. One is called the formation of oligomers, these especially toxic forms of amyloid. And this form can't be detected by current either blood tests or brain scans. And so we're hoping to develop ways to both detect them and to eliminate them.
Even if you're getting a diagnosis using a PET scan, these are not showing up?
Right.
Wow.
Well, I mean, some of the things that we're doing now have to do not only with the oligomers, but also the microglia, the inflammatory cell of the brain. And we think that by finding the right molecule to target with a safe drug, that it might be possible to control the inflammation.
And the inflammation is leading to the increased risk of developing a dementia?
Well, it's part of how the brain is damaged, partially because the amyloid is toxic and poisonous, and partially because the amyloid and the oligomers activate the inflammatory cells that themselves try to clean up the brain. But whenever they can't do that adequately, they sort of add to the problem. Though they are trying to reduce inflammation, they end up contributing to it.
Okay, that's interesting. What else might be contributing to the risk of inflammation in the brain?
Well, any sort of insult, either traumatic or inflammatory, anywhere in the body can trigger excess inflammation in the brain.
Mm-hmm.
A lot of this will go back to lifestyle and diet.
And genes.
Right.
Choose your parents well.
Yeah. Can you say a little bit about what we know about the genetic risk markers for Alzheimer's?
Well, about half of the patients with Alzheimer's have a risk gene called ApoE. And ApoE comes in 3 different types, and most people have the ApoE3 type, but there's another called E4, which increases risk for Alzheimer's, and a third called ApoE2, which decreases the risk. So everyone has 2 copies of ApoE, one from each parent. And so the net effect is that they're different genotypes, and they control the risk for Alzheimer's in about half of people.
Mm-hmm. And would you encourage the, children of people with Alzheimer's to get themselves tested?
Well, we encourage people to do healthy things anyway. Part of the problem with encouraging testing for pre-symptomatic family members is that there's not perfect protection against discrimination for insurance and employability. So that's things every family has to weigh.
Yeah, that makes it a difficult decision, and of course the personal choice of whether you really want to know or not.
Right.
Are there a lot of ongoing studies looking at people with genetic predisposition to Alzheimer's?
Yeah, everyone who enters an Alzheimer's trial now gets a genetic profile. There are about 100 different genes that play some role in the more common forms of Alzheimer's.
Wow. Okay, that's extremely interesting.
What does that mean, common forms of Alzheimer's? Is one of the proteins more common than the other causalities?
Well, the pathology is pretty similar for all forms, but the gene names and the gene types have different, the risk size is different. There are very rare forms of genetic changes that guarantee Alzheimer's, and those are usually early onset, beginning in the 40s. And in that case, everyone who has the mutation gets the disease. However, for most people with late onset disease that appears to be sporadic, there's some combination of these other 97 genes that we have a hard time pinning down on an individual basis.
Very interesting. Yes, as you said earlier, be careful who your parents are.
Right.
Yeah. You said earlier that, Alzheimer's is just one kind of dementia, and there are many different types of dementia, and now we're talking about there being many different types of Alzheimer's even. How might care be differentiated between these different kinds of Alzheimer's and, by extension, the different types of dementia?
Well, care is tailored for the main symptoms. With Alzheimer's, memory problems tend to be the most dramatic, whereas with a disease like Parkinson's disease, the movement disorder is more prominent. Or with frontotemporal dementia, there can be changes in behavior and language that are different from what happens in Alzheimer's.
And we've heard a lot recently about some of the existing medications in Alzheimer's care. Would you be able to share with us what those are?
Sure, there are two classes of medications that are used for Alzheimer's. One class is called the cholinesterase inhibitors, and that class has three different drugs, donepezil, rivastigmine, and galantamine. They all have some similar effects, that is, to help the brain compensate for the deficiency in a transmitter called acetylcholine that happens as the disease progresses. Galantamine has an unusual property in that it also has anti-inflammatory activity. So it has both the effects on acetylcholine and its own effects on inflammation. It seems to slow or prevent people from going from the moderate stage of dementia to the severe stage, and we think that's very important. The other class of compound or drug is the NMDA inhibitor, a drug called memantine that blocks a form of poisoning called excitotoxicity.
And the Mementine's been around on the market for a little while longer, is that right?
They've both been on the market for a long time. 20 years or more.
There's been a lot of press recently about some new medications that are used to potentially treat Alzheimer's. Can you say something about the new drugs? Some of them have complicated names like Aduhelm and Leqembi.
Yeah, these are anti-amyloid antibodies, and they're given by infusion. These are antibodies, the same sort of antibodies that your body makes to attack infection like bacteria or viruses. But the antibodies in this case are aimed at the misfolded forms of amyloid. And they help to clear the amyloid out of the brain. There are two that are currently approved, aducanumab and lecanemab.
And there's been a lot of excitement about these new medications. From your perspective, how hopeful should we be at this point?
Well, we still have a long way to go. The medicines do slow decline, but that effect is rather modest, about 30 to 40%. Slowing, which means about 6 months longer at any particular stage of illness. But we think we can do a lot better with combinations of these and other medications.
Is there a particular stage of dementia that you would recommend starting some of these new medications?
Well, they're really only approved for people in the mildest stage, either with mild cognitive impairment or with mild dementia.
So you would recommend that somebody takes these in the earlier stages. Is there anything available to those people in the later stages of the disease?
There are the same medications that I mentioned before, and it's possible that some of these medications, the new medications, might help later stages, but they just haven't been tested yet.
Mm-hmm. Some of the medications that have been approved are extremely expensive. What are your thoughts on making sure that people can get access to the new medications?
Well, the most recent medication has been approved by Medicare services, and the implication is that if physicians will register patients online, then Medicare will cover those new medications.
Great. That's exciting. In terms of finding out more information about medications, what's a good resource for family caregivers to look up?
The major clearinghouse is the Alzheimer's Association. And their URL is www.alz.org.
Great. If you took some of these new medications in the earlier stages, do you think it will ever be possible to cure dementia, or is slowing the decline the best we can hope for?
I think we can hope for preventing, but I'm not sure how much we can expect to restore. One of the newer medications that's going to be evaluated next year, there are about 45% of subjects in the trial who didn't progress at all. And that's, I think, really the best that we can hope for at this point. And if we began a treatment when people had no symptoms at all, perhaps we could prevent the disease from ever developing.
That seems like incredibly exciting news that one of the newer medications that's still presumably in trials is actually preventing decline of the disease.
Right.
And is that the kind of research that you're getting most excited about at the moment?
That's certainly the research that's already made it to FDA approval. Some of the newer strategies aimed at inflammation may be more important to try and get the effect size larger.
And most of the medications that we've just been talking about focus on this amyloid plaque buildup in the brain. We also hear about tangles. Can you say something about tangles and whether there are any medications that we are hearing about that look at that side of the disease?
So tangles are made up of a protein called tau, which is also a normal protein inside neurons. There's an approach where the gene for tau can be knocked down, and that may be a way of intervening with preventing both the amyloidosis and the tauopathy. You can treat people with things called antisense oligonucleotides, and they will depress the expression of the genes for the amyloid protein and the tau protein.
And aside from medications, are there other things that people with maybe a genetic marker for Alzheimer's can do to help slow down that buildup of the amyloid in the brain?
Well, certainly physical exercise, proper diet, mental stimulation, and social engagement are all important things that I always talk about with my patients.
Has there been much study on some of those more holistic things like socialization or improved exercise? Have we got any clinical trials looking at the effects of those?
Yeah, there are several going on around the world now. There's a particular program called the FINGER Finger Program that's developed in Scandinavia from Sweden and Finland that looks at all these things together and tries to parse out which ones are the most important and how to combine them.
And any early insight on what things make the biggest difference?
Well, I mean, physical exercise is still one of the most important things, and we recommend that people have at least 3 exercise periods every week in which they spend about 30 minutes at each period doing vigorous exercise, either brisk walking or weight training.
And I know that there are medications often used for patients who have dementia and or Alzheimer's, and they're often used to treat some of the symptoms rather than the causes. Can you say something about those?
Well, the ones that I mentioned before are really all symptomatic treatments. In addition to those, we often use antidepressants or antipsychotics, depending on whether those are very prominent symptoms.
I could imagine that the symptoms of depression might be exacerbated given the role of social isolation for people with dementia. Is that true?
Yeah, that tends to increase the rate of decline. The more isolated you are, the faster the dementia will progress.
What percent of the patients you see do you think have some form of depression?
So depression in isolation is very common. Depression as part of Alzheimer's is less common, but it's an important thing to look for depression in everyone because it's treatable.
And are there special ways of approaching somebody with dementia to detect depression?
There are scales or a number of bedside tests, neuropsychological tests that we can use to try and figure out which parts of the brain are involved and whether there's depression or anxiety, other things that are complicating the picture.
When a new patient presents in your clinic, what are some of the first questions that you ask?
I often get histories both from the patient and from a caregiver. The caregiver tends to be more accurate. Often patients with Alzheimer's don't have the insight to know that anything's wrong. There are probably a third of patients who never think anything's wrong with them for the entire course of their illness.
Gosh, so it's really important that you're able to talk to people within their circle and not just rely on the patient's perception of what is going on.
Right.
They need advocates with them.
Denial seems like a particular problem for people with dementia. And is there anything that can be done to help alleviate some of the denial?
So what's often called denial is actually loss of insight. It's not this sort of psychiatric denial where people are just not facing the problem. The problem is neurological. They can't actually see the illness. It's a neurological condition called anosognosia, in which the affected patient cannot see his or her illness.
Right.
It's sort of like there are places in the brain where you can have strokes in the parietal lobe where you can not recognize half of your body, where part of your body seems foreign for some reason. And it's that sort of problem that's also true in Alzheimer's. In the case of Alzheimer's, what they can't see is the illness.
That's very interesting. I think that's very insightful for a lot of our listeners as well. We hear a lot from families and from their caregivers about not being able to explain what's going on, and they take it very personally. And I think knowing that it's got a neurological root and a reason for it is probably quite helpful for people to hear.
Yeah, it's very frustrating when your family member asks you the same question every 5 minutes for hours on end. Families just have to learn to sort of not react.
And if somebody can't see their own illness, is there a way of helping them to see it?
The only way is to try and cajole them into sort of going along with their families, to try and persuade them that at least, if you don't believe you're sick, you must at least think that we're all here trying to help you. And if you'll just do us the favor of taking these medications or whatever. I mean, it's sort of a negotiation.
Appealing to the sense of family and community to take the medication or receive treatment because it's the right thing to do to help the whole family.
Right, because you're never going to reverse the loss of insight.
Mm-hmm.
And I think this issue of denial is something that we come up against quite a lot. So we have the denial from the patient, which I think you've given us a good explanation and understanding of. But there's a lot of denial from their support system, from their family. And there seems to still be some kind of stigma and a shame associated with Alzheimer's.
Yeah, I think family members tend to feel embarrassed on the behalf of the patient. Since the patient doesn't recognize the problem and doesn't feel embarrassed, the family members try and protect them. That, I think, unfortunately feeds into the stigma, when in fact the easiest thing for everyone is just to sort of face the problem. I mean, I wouldn't say it's easy. Probably it's just the most direct way to deal with it.
Yeah, and people tend to, when you explain that situation to people, they're extremely understanding and extremely kind. I think that's what we have found as well in our experience is if you are able to explain to other people what is going on, they will treat the patient with a lot of kindness, a lot of patience, and a lot of sympathy.
That's typical. That once they sort of overcome the barrier of telling people and making it known that there's this problem, there's usually a lot more support.
Yeah, I think that's something that we're trying to help our families with as well. Understanding and almost normalizing the situation.
Right.
And reducing that shame for sure.
So our role can often be in helping families adjust to what life means when they're taking care of a loved one with dementia. What are your thoughts on getting the family the best support possible when they're taking care of a loved one?
Well, I mean, support for the family is essential because it's very exhausting to take care of patients with Alzheimer's disease who need continuous supervision and a variety of activities of daily living that they would normally be able to do for themselves now must be taken over by the caregiver. I mean, there are a number of organizations in the community, like the Alzheimer's Association in New York City. There's Care in Kind, and these are all things that help support the family.
Dr. Gandy, we have covered an enormous amount of ground in a short space of time here, so we really appreciate having you answer some of these questions. I think we've dug in and really understood a little bit better the use of medications in treatment, as well as covered some of the other topics. I want to thank you for your time. Really appreciate you coming on.
Sure thing. My pleasure.
And if there is a chance that somebody listening to this is interested in becoming a participant in any of your trials, is that something that we can help you with?
The ADRC at Mount Sinai has a website, and clinicaltrials.gov also has a listing of all trials at all the institutions and hospitals nationwide. People can get information either from that website or from the Alzheimer's Association or from their local Alzheimer's Center.
Okay, great. Thank you so much for that.
Thank you.
I thought one of the most interesting things that Dr. Gandy said was that what we often think of as denial is actually a symptom of the disease itself.
Yeah, I never really thought about it that way myself, and I think that's really important for us to all remember as we, interact with people with dementia and Alzheimer's. And I also feel a lot more knowledgeable now about the role of medications and how we're using them to treat people with Alzheimer's.
Yeah, there's definitely some cause for hope around these new medications, although, the current effect is somewhat modest.
Yeah, he was saying only a 6-month delay in the progression of the disease.
Although, sounds like some of the investigations that are ongoing do show potential for greater delay of the disease.
Yeah, and I think it's important to remember that medications are only part of the puzzle, that there's other things that you can try. You can modify your diet, you can do exercise, you should keep socializing, and these are all other things that you can do and try, and that links back to what Dr. Swerdlow said in our first episode.
If you're interested in getting additional support for yourself or a loved one with dementia, then you can get in touch with us by visiting our website, www.hilizzy.com. That's www.hilizzy.com.
Or you can call us on 234-567-9449.
Or you can email us as well, info@hilizzy.com.
Memory Matters is brought to you by Lizzy Care.
It's hosted by me, Sarah Gorenstein.
And me, Ollie Fielding.
And our producer is Mia Sullivan. If you like this episode, please follow us on your favorite listening app and consider leaving us a review or rating, because it'll help people find our show.
Take care, everybody.